জি ম্যাডাম।
সবাই জয়েন করছেন?
জি ম্যাডাম, ইউ ক্যান স্টার্ট নাও।
ওকে ওকে, ম্যাডামরা সবাই জয়েন করেছেন? ওকে ওকে, থ্যাংক ইউ। Assalamu alaikum and good evening. Welcome you all to our regular Zoom-based activities of the Oncology Club. The continuing medical education series. Today is our topics is our ovarian cancer in pregnancy, dilemma and the controversies. As all we know, the ovarian cancer, it is the most devastating malignancy in gynecological cancer, and in every 2 minutes, one woman diagnosed in ovarian cancer. So we are too much concerned with ovarian malignancy, and for that, and now the today's topics is the ovarian cancer in pregnancy. Today's our faculties are Professor Dr. Amita Maheshwari. She is head Gynae-Oncology, Department of Gynecological Oncology in Tata Medical Center, Mumbai. Dr. Abraham Perisil sir is the senior consultant on gynecological oncology, Sultan Qaboos Comprehensive Cancer Center, Cancer Care Center, Muscat, Oman. Dr. Santosh Menon, he is Professor, Department of Pathology, Uro-Oncology and Gynec-Oncology, Disease Management Group, TMS, Mumbai. Dr. Joya Ghosh, she is Professor, Department of Medical Oncology, Tata Medical Hospital, Mumbai. Our today's presenter is Dr. Farhana Kalam. She is gynae-oncologist from Department of Gynecological Oncology, National Institute of Cancer Research and Hospital. And presenting the mentors are Dr. F.M. Kamaluddin. He is the Scientific Secretary, Oncology Club. Dr. M.M. Shariful Alam, General Secretary, Oncology Club. We are sorry today that our president of Oncology Club, Professor Dr. A.M.A. Hai sir, he is sick today, and so he cannot join, who is our regular inspector and regular with us. So, sir is absent with us today. I request Dr. Kamaluddin Bhai to say something to today's session and give us permission to start the session. Dr. F.M. Kamaluddin, please.
Thank you, Shana. Welcome you all to our session, and we hope that it will be an exciting session. So I think we can start without wasting any time.
Okay. Thank you, Dr. Kamaluddin Bhai. Now I request Dr. Farhana Kalam to present her cases. Dr. Farhana Kalam. And we are also very happy that we have the one detailed presenter from Sir Sorimullah Medical College and Hospital, Dhaka. At last of all the case presentations, she will present one interesting case, and we request all of you to stay with us up to the end of the session. Farhana Kalam, please. And before starting the program, I request all the participants in the session to answer the poll questions, as your questions will not be who is answering the question, who is right or wrong is not seen. So please, everybody is requesting to answer the poll questions. After every case scenario, we will show you some poll questions, and you are requested to answer the poll questions. It is for just brainstorming, and nobody will know who is the correct answer, who is giving, and who is the wrong answer. So please, the answer all, and all the participants are requested to put your questions, other questions in the chat box. Farhana, please.
Good evening to all. My first case, Mrs. X, 25 years, para 0, had heaviness and pain in lower abdomen 9 months back. Then she was diagnosed as a case of ovarian tumor by ultrasonography and tumor marker, especially by CA-125. Then she underwent laparotomy followed by left-sided salpingo-oophorectomy on June 2021. Histopathology report showed dysgerminoma and capsule intact. She received no adjuvant treatment and advice for follow-up. She became pregnant during her follow-up period. Then she consulted with gynae-oncologist at 12 weeks of pregnancy with a report of ultrasonogram. Ultrasound showed one solid irregular hypoechoic soft tissue mass 4.2 into 3.6 centimeter at left adnexal bison. a solid irregular soft tissue mass 5.8 into 3.8 centimeter at the left lumbar region, suggestive of recurrent mass at the left adnexal and left lumbar region and single intrauterine live pregnancy of about 12 weeks. Then she was advised for MRI and tumor markers. Here is her MRI report, which showed gravid uterus, multiple peritoneal malignant deposit at central and right upper abdomen, 11.5 into 6 centimeter, left adnexal 9 into 6 centimeter, and cul-de-sac 8 into 5 centimeter, causing compression of distal part of left ureter, resulting in left-sided mild hydroureteronephrosis and encasement of rectum, left internal iliac lymphadenopathy. And these are the her tumor marker, which was done on 3rd January, CA 125, 28.2, CA 99, 4.9, CEA 0.59, LDH 290 unit per liter. Then the patient was referred to National Institute of Cancer Research and Hospital. We examined her and found uterus 18-week size. On bimanual examination, heart fixed mass felt in pouch of Douglas compressing rectum. An ultrasonogram for follow-up was done and showed single live pregnancy of 16 weeks 2 days, solid irregular hypoechoic mass 5.6 into 5.3 centimeter is noted in left adnexal region, possibly recurrence, and a lobulated hypoechoic area measuring about 5.7 into 4.1 centimeter is noted in epigastric and left hypochondriac, may be matted lymphadenopathy. Again, tumor marker was done on 24th January. It shows LDH 427 unit per ml, alpha fetoprotein 11.1 nanogram per ml. With those above findings and investigation report, we placed the patient in multidisciplinary tumor board of our hospitals. And she was advised for chemotherapy by paclitaxel and carboplatin and continue her pregnancy. Thank you all for patient sharing.
Now I am requesting Mr. Mehdi to show the poll questions of the case number 1. Mehdi, please.
Ma'am, sorry, I have faced some difficulties, technical difficulties to show full question. Farhana Kalam, madam, please stop your sharing.
অভি তোমার শেয়ার স্ক্রিন বন্ধ করো, তোমার স্ক্রিন শেয়ার বন্ধ করো।
হ্যাঁ বন্ধ, sorry, my screen share is closed.
Sorry, madam, I have faced some difficulties to show full question. Please continue the session.
How? Because it
The volume is very low.
Sir. Sir, my voice low, sir?
Sorry,
Sir?
the volume is very low. I can hardly hear what's going on.
Sir, can you hear me?
Faintly.
But here others, Santosh sir. Santosh sir is here.
Yeah, I can hear you. I can hear you, doctor.
Yeah, I can
Okay, that
also
is-
hear Amita here.
Yes,
I
okay.
think Dr. Abraham, you need to check your at your end.
Okay,
But sir,
all
you
right.
may need to log out once and log in again.
Yeah, all right. Okay, I'll do that.
Madam, আপনি অনকোলজি ক্লাব থেকে হচ্ছে আপনি
মেহেদি সাউন্ডের প্রবলেম হচ্ছে, কেউ শুনতে পাচ্ছে না কোনো কথা। এটা কি পোল হচ্ছে এখন?
স্যার আসসালামু আলাইকুম।
এখন কি পোল হচ্ছে?
না স্যার, পোল কোশ্চেনের জন্য ট্রাই করা হচ্ছে, মেহেদি একটু প্রবলেমে পড়েছে সম্ভবত।
তাহলে পোলটা বাদ দিয়ে প্রোগ্রাম প্রসিড করো। শাহানা,
জি।
প্রসিড করো প্রোগ্রাম। শাহানা, সবাই ওয়েট করতেছে, প্রোগ্রাম প্রসিড করো, তাহলে পোল ড্রপ করো, পরে করো। হ্যাঁ, হ্যালো শাহানা, আমরা প্রোগ্রামটা কন্টিনিউ করতে পারি আমার মনে হয়। হ্যালো
স্যার শাহানা
Shana
ম্যাডাম,
madam is absent now.
ওকে কল করো, ফারহানা ওকে কল করো।
ইয়েস স্যার, আই ওয়াজ কলিং।
হ্যাঁ অভি, আমাকে তো ও মেহেদি বলছে আপনি ইয়া হয়ে যান, আমি অনকোলজি ক্লাব যে সকালের প্রোগ্রামের জন্য আমি ঢুকি যে এই জন্য ওইটা দিয়ে আমার।
পার্সোনাল নামে জয়েন করো আবার।
আচ্ছা ঠিক আছে, না ও পারছে না, আমি তাহলে ফোর কোশ্চেন গুলি আমি বলছি এমনি মুখে বলি।
ইউ প্রসিড অন, প্রসিড অন।
Okay. The first question, Farhana, please go to the first the case, please again, the shortly. Farhana, please. Slideshow. to them.
This is our first case. Do I need to read it again?
Yes, just shortly, you please.
Okay, welcome back. I'm sorry for the interruption. This is our first case. Mrs. X, 25 years, para 0, had heaviness and pain in lower abdomen 9 months back. Then she was diagnosed as a case of ovarian tumor by ultrasonogram and tumor marker. She underwent laparotomy followed by left-sided salpingo-oophorectomy on June 2021. Histopathology report showed this germinoma capsule intact. She received no adjuvant treatment and advice for follow-up. She became pregnant during her follow-up period. Then she consulted with gyne-oncologist at 12 weeks of pregnancy with a report of ultrasonogram. Here the report showed recurrence at left adnexa and left lumbar region with single viable intrauterine pregnancy. And she was advised for MRI and tumor markers. This is our MRI reports, which also give us idea about the recurrence and metastasis. This is our tumor markers. Here we show LDH level is high, 290 unit per ml. And with this report, she was referred to NICRH. Here we examined her, found uterus 18-week size, heart fixed mass in pouch of Douglas compressing rectum. Ultrasono now shows single live pregnancy of 16 week 2 days, solid irregular hypoechoic mass, and the lobulated mass may be matted lymphadenopathy. We did tumor marker. Now LDH level is rising, 427 unit per ml. With this above finding, we placed the patient in multidisciplinary tumor board, and they advised for chemotherapy by plaquetexel and carboplatin and continue her pregnancy. This is the short case summary of case 1. Thank you all.
Farhana, I couldn't show the questions which was given in chat box at beginning because second time I was logged in. So please show the chat box questions. Please ask the chat box questions.
Thank you, madam. There are many questions in our chat box. First is 25 years lady, para 0, presented with adnexal mass. How she would be evaluated ideally?
What is your answer, please? What is your answer, Farhana? You please
Madam,
explain.
I think if that lady present to us with this complaint, we need to evaluate her by taking short history and then examination and some imaging like ultrasonogram. And here the patient is not pregnant, so I can do CT scan and tumor markers like CA125, CEA, CA199 for epithelial ovarian variety of ovarian tumor, and to exclude germ cell tumor, I want to do some tumor markers like alpha fetoprotein, LDH, beta HCG, and with this report, I will proceed with this patient.
Okay. Is Abraham sir or Umita ma'am, what is your opinion regarding this? Obi? Are they in the
I think Dr. Farhana
Yeah.
sort of laid it out clearly. The history, the clinical examination, and tumor markers. I may not have done CA 99, and but the other germ cell markers definitely I would have done. And if there's any suspicion of granulosa cell tumor, I might have done a AMH or inhibin B as well. But otherwise, yes, like she said, a CT scan, if for all suspicious adnexal masses, could be done if she's not pregnant.
Yes, that during pregnancy, sir?
During pregnancy, CA125, HCG, alpha fetoprotein, and inhibin A are not reliable markers. And CT scan should be avoided, but MRI scan could be done. Ultrasound and MRI scan can be done during pregnancy.
Yes, sir. But in some areas, sometimes in the patients, they are attending in a peripheral hospital or in a rural area. In that cases, usually we don't get the MRI facilities. In that area, how can we evaluate the patients if a pregnant patient is attended with adnexal mass with pregnancy, whether it is benign or malignant, and accordingly?
কেনা প্রসেস শুরু হয়ে গেছে আজকে থেকে কথা পাইনি সময় লাগবে অনেক টাকা দেব এরপর কি করা হবে অনেক সময় লাগবে
Please, like Shakila, mute please. Shakila,
হ্যাঁ ম্যাডাম আসসালামু আলাইকুম
mute please. Sir, Abraham sir.
Oh, well, if in a peripheral hospital, if they have ultrasound, then that would be the first thing to do after the, I mean, even tumor markers, they may not be able to do.
Yes,
And
sir.
on ultrasound, if
Ultrasound
it
with
is
color Doppler, sir. Ultrasound with what type of a single investigation, whether in a like a rural area, in a Upazila health complex, in that cases, at least a sonologist is available. In that cases, we can go for the ultrasonography with color Doppler. Everybody are requested to mute, please. Mute yourself, please. Sir. Abraham, sir.
yes, if ultrasound is available, then they should do ultrasound. And then, there are different ways of looking at it, either the IOTA system or the, some scoring systems may be there to help you. Basically, the IOTA system has benign criteria and malignant criteria. So if it's solid areas, papillary projection, size of the tumor, these are things that, people can make use of to try and find out whether it is benign or malignant.
Okay, okay. Farhana, I am not seeing the previous poll questions as because I have logged in second time. So what is the other questions in chat box, please?
Madam, here someone mentioned about that she undergo only left-sided salpingo-oophorectomy. Actually, what should be the ideal surgical procedure and whether frozen section would be needed or not, as because in periphery hospital there is no frozen section facilities.
Yes, frozen sections is necessary. I think frozen sections, sir.
Yeah, ideally, this if it's a high degree of suspicion, such patient should be referred to a higher center.
Yes.
I mean, otherwise mistakes will happen. You see, if they're going to manage in peripheral, then their surgery may not be complete. The staging may not be complete, or there may be spill of the tumor. All these things will happen in the peripheral centers. So I think the message should be that if it's a highly suspicious mass, then they have to be referred to a higher center.
Okay, sir. Someone says the another questions. Why paclitaxel carboplatin regime is selected here? Why Dr. Joya, please. Dr. Joya.
Yes, good evening, Dr. Shahana and all of you. So, for a germ cell tumor, I would not use paclitaxel and carboplatin. So, I mean, there are reports of the use of BEP, although I don't have personal experience of using BEP with a pregnant lady. We have used platinum in pregnant ladies, but it is shown, I mean, it is as per literature, it is there that BEP can be used in patients with pregnancy. So I think that is something that can be considered in these patients. Of course, discussing, because from second trimester onwards, we can give them chemotherapy. So even if you are not able to give the blue, at least this platinum etoposide is something that we should consider, because for a dysgerminoma, one would really not want to give paclitaxel and carboplatin.
But as we know, will you use the paclitaxel or the carboplatin or the cisplatin, as because all we know the cisplatin, it can carboplatin is the more rapidly goes through the placenta. So in that cases, even we will go for the carboplatin in other malignant ovarian tumor in pregnancy, even after that.
No, so what I meant was that because this is a germ cell tumor, I would use a cisplatin etoposide, a BEP regimen,
Yeah.
rather than a paclicarbo. Yeah.
EP or only EP?
So
Yeah.
if there is a doubt and we are not sure about the lung toxicity, and it is difficult to assess lung functions in a pregnant lady, I would go ahead with cisplatin and etoposide, because after 1 or 2 cycles, by the time she is able to deliver, and one would stop chemotherapy about 3 to 4 weeks prior to the delivery, and they'll try to take her to term and stop chemo about 2 to 3 weeks prior to the planned or expected date of delivery, and then take it from there.
Okay. Another question is that how does she need adjuvant chemotherapy after delivery, as she has already, if she gets at the dysgerminoma, the patient receives the C-cycle EP, then if after delivery, does she need adjuvant chemotherapy? after delivery?
No, so that would depend upon how many cycles we were able to give before and how many. So, she will need a total of 4 cycles.
Yeah.
And if she's received, say, like 2 or 3 before, then post delivery, we will give her 1 more cycle.
If
Whereas, yeah. So the whole thing would depend upon how many we were able to deliver before pregnancy and how many, and 1 more after delivery. So that would be. And after delivery, if it is like you said that she had multiple peritoneal deposits also, if
Yes.
I understand.
Yeah.
So then we would definitely try to use bleomycin post delivery at least. Because for stage 3 and stage 4, one wants to give at least 4 cycles of BEP or at least 3 BEP and 1 EP. That is, for a non-pregnant patient, that is what is the standard. So for pregnancy, as I said, that at least immediately before the delivery, if you're not sure about the bleo, that is something that we'll have to take a decision on a case-to-case basis. But as soon as we are able to deliver, we should be able to give the bleomycin, yes.
Only bleomycin. If
No, BP. What I meant,
if
bleomycin is bleomycin, etoposide, and
if
cisplatin.
bleomycin is not given during pregnancy, if 4 cycle of the EP is completed during pregnancy and she delivered, after that she will get only the bleomycin?
No. We don't give single agent bleomycin.
Okay.
So, after she gets delivered,
Yeah.
then
Yeah.
we'll need to look at the tumor markers, do a
Yeah.
proper CT scan and see what is
Yeah.
this disease and then take it from there. Yeah.
Yeah. So another question is in follow-up period, after how much time a patient can plan pregnancy in this kind of history? This is Mohammed.
No, meaning this patient was pregnant and then sorry, I couldn't understand the question. Can you please repeat that?
Yes, it is written in chat box that in follow-up period, after how much time a patient can plan a pregnancy in this kind of history? Probably he is from Egypt, Muhammad Usman.
So, like if we have a lady with dysgerminoma, usually, or a germ cell tumor, usually after chemotherapy, we ask them to wait for about 2 years. And after that, they can plan for pregnancy. The main reason being whatever chances of recurrence are most common in the first 2 years, and also for any residual chemotherapy effects to get over. So, that is why we would want to wait for about 2 years post completion of chemotherapy before they plan pregnancy.
Jaya, Amita here. Maybe I'll
Yeah.
slightly differ from you on this. Conventionally, it is 2 years.
Mhm.
But if you have given chemotherapy, the risk of relapse is anyway very low. And I think if the concern is chemo-induced gonadotoxicity, that won't last for 2 years. So if patient wants to conceive earlier than that, would you not allow her to go for pregnancy? To plan
Yes,
pregnancy?
we can. So, so if somebody wants, especially that occurs like if somebody is like, say, 32, 33 already. So then, but maybe at least we would want to wait for a minimum of 6 months post or to 1 year post chemotherapy. So that is the time that I think, because immediately after chemotherapy conceiving, I think a minimum, I don't know if there are any defined time period post that, but that is what. So it's not that, if somebody conceives, say at 8 months post treatment, we will ask them to terminate just because she's not completed 2 years.
Yeah. So many times, in fact, they want early pregnancy, and the other concern is, or one ovary is already out plus gonadotoxicity of chemotherapy. So delaying it, I don't know. Conventionally it's for 2 years, but I really don't see much wisdom in waiting or in counseling after understanding the risk of relapse, whatever. I think conception can be planned. Maybe 6 months or 3 months or 4 months.
Yeah, but at least for 6 months to a year. So at least for 6 months, one would want to wait for, at least for her to recover post chemotherapy before,
And anyway, practically many patients will also develop, 80% develop chemo-induced amenorrhea. So ovulation will be anyway is not there immediately after chemotherapy.
Yeah, so that's why I said that practically, people at least before a year after completing chemotherapy, by and large, by the time they resume menses, it's about anywhere between 6 months to 6 to 12 months. That is the time that they resume their menstruation post chemotherapy. So even even in advanced stages, when we give 4 cycles of BEP, about 85% of these patients resume menstruation. And the time to resume it is around 6 months to a year. So practically speaking, before a year, it is very difficult for them to.
Yeah, so maybe 6 months is a reasonable, and the other message should be if they conceive, against your advice, termination is not recommended by and large. So if conception is beyond say 3-4 months or 6 months, termination of pregnancy is not recommended.
Yeah, sure. So we generally advise them to wait, but then if they conceive earlier, we don't terminate and we just follow the pregnancy carefully.
Jaya, it is Kamal.
Yes, sir.
Yeah,
Good
yeah.
evening, Dr. Kamal. Yes.
So people are concerned about the teratogenic effect of chemotherapy.
Mm-hmm.
Chemotherapy, they don't want the pregnancy because they're scared of this teratogenic effect. So is there any time frame that after how many months they will be free of this? Because there are many drugs, there is level 2 evidence that it is teratogenic, something like that.
Yes, so the
People are
chemotherapy.
scared. As Amita said, that people want pregnancy, at the same time they're also scared. So what should be our ideal recommendation?
So as we mentioned that, conventionally it has been about 2 years, but if they want at least after a year, they can plan. I think that is what, especially, somebody's 32, 33, then, may not be wanting to wait for another 2 years. You can wait for a year and then start. So there is no hard and fast, I don't think there is a blanket line there, but that is what is there.
Yeah, so generally if you speak with infertility experts also, maybe 4 to 6 months post chemotherapy, but whatever, I think beyond that gonadotoxic effects don't last, like those gametes will not be there.
So Amita, can I sum up like the comments of you and Jaya like that we recommend to wait at least for a year, but if somebody become pregnant after 6 months, there is no need to terminate it with the fear of all these things.
Right. So termination, I would say, even if my patient, that doesn't happen, but after 3-4 months also, if they conceive and if they want pregnancy, we won't advise termination. Just a careful observation of the pregnancy and do a proper ultrasound for any anomalies. So
Plan should be done after 1 year minimum.
Yeah.
But if it happens earlier, should
Continue the pregnancy.
Decision. This is the message.
Yeah, there is.
Yeah.
Yeah.
During pregnancy, I think chemotherapy should be given after 20 weeks.
Yes, sir.
And carboplatin and paclitaxel are probably the safest drugs to give during pregnancy. But yeah, like I said, like was said, maybe for germ cell tumors, I'm not sure how much difference in efficacy there is. Although in non-pregnant state, etoposide, the BEP regimen is preferred. I'm not sure. Anybody has used carboplatin and paclitaxel for germ cell tumors during pregnancy?
No, not for germ cell tumors during pregnancy. We have generally used paclitaxel carboplatin, but
So we haven't had a germ cell with pregnancy. We had a epithelial ovarian cancer with pregnancy, and there we have used carboplatin. But of course, carboplatin and paclitaxel we've used for breast cancer patients with pregnancy quite a bit. So both paclitaxel and carboplatin are safe to use in pregnancy. So that is what I've used. So as I said, for germ cell tumors, as per literature, BEP can be used, but I don't have a personal experience of using BEP during pregnancy. And a bit of a challenge is the degree of nausea, vomiting that happens with cisplatinum and the pregnancy. I think those are some of the challenges which are there. But
another point is, the placenta should be examined after delivery and probably sent for histopath.
Sir, there is question that is, does she need the complete surgical staging again during her cesarean section? Will she need, the question is that, will the lady needs the induction of labor or she needs the cesarean delivery at the completion of the viable age? So this question.
That's an obstetric.
Yeah.
Obstetric indications have to be followed.
Yeah, yeah. There
I
is
mean,
no
if she has
contraindication of.
responded-
Yeah, no
Yeah, if she has
contraindication.
responded well to the chemo, then she could deliver vaginally.
Yes, sir. If she undergoes the cesarean delivery, does she need the complete surgical staging? I think it is not needed because it is already advanced stage disease, so she needs not the surgical staging. Yeah.
This particular case, yes, it's
Yeah.
already.
What was done initially? I mean, if disease is seen, I missed initial part.
Only LSO.
So maybe if one is, I mean, seeing viable tumor now, momentum or deposits, so
Momentum,
they,
yeah.
that should come out. Of course,
Yeah.
other ovary we can leave if future fertility is desired, but whatever gross, so maybe a good idea to take a vertical incision for if patient is planned for a cesarean section, not a transverse one. And if she's otherwise, I mean, if setup is good, then do omentectomy and remove metastatic deposits if seen at the time of surgery.
We have several cases, so I think we'll go for the second case. Yes, another people, if it should be complete surgery during the no. Okay, Farhana, please go to your second case, please.
Welcome back to our second case. Mrs. X, 20 years, primary gravida, diagnosed as a case of 20 weeks of pregnancy with ovarian tumor. She underwent laparotomy followed by left ovarian cystectomy and biopsy from suspicious area on 19th January 2021 at her 26th of pregnancy due to severe lower abdominal pain. Histopathology report showed resected tissue from ovarian mass and tissue from gut showed metastatic granulosa cell tumor. Differential diagnosis was noted here, that is ovarian dysgerminoma, and omentum showed metastatic granulosa cell tumor. And then she was in regular antenatal checkup and she underwent cesarean section at her 37 weeks of pregnancy due to IUGR with breech presentation with polyhydramnios with PROM. But unfortunately, her baby died at 40th postnatal day. Then this patient attended to NICRH on February 2022. Here as there is a discrepancy in her histopathology report, so we advise her immunohistochemistry. Immunohistochemistry showed granulosa cell tumor, inhibin positive in tumor cell, calretitin focally positive in tumor cell, PLAP negative, CD117 negative. And we also advise her some investigation like CT scan of whole abdomen, which showed no residual disease, no ascites, no lymphadenopathy, CA125, 40 unit per ml, inhibin B reports are biting. And now we advise her for staging laparotomy. Thank you all for patient sharing.
Again, no full question. So we have the question to Dr. Abraham sir, please. Sorry, Abraham sir, no, that is Dr. Santosh sir.
Madam, can you see the poll question?
Yeah, yeah. Yes, it is already discussed. Everything discussed, yeah. Okay. Farhana, it is already discussed, yeah.
Okay, okay. Okay.
My question is to Santosh Menon sir. As there is here is the two diagnostic dilemma, as there is the granulosa cell tumor and also the momentum and other excess tissue. There is also the differential diagnosis dysgerminoma. And is there any relationship between, or there is, why this type of flu, even after the primary disease and also the metastatic disease, both were the granular cell tumor and D-germinoma? How this type of, is there two histopathological report where the there is any similarity between these histopathological two report? Why this type of reporting? Santosh sir, please.
Dr. Shana, I cannot tell why somebody has reported the Dysgerminoma, but yeah, I don't think they are a differential diagnosis, because generally Dysgerminoma is a straightforward diagnosis. But if the Timish tissue is limited and poorly fixed, maybe somebody can mistake them for each other. But generally, a granular cell tumor is hardly mistaken for a Dysgerminoma. And the other thing is, IHC has clearly proven this to be a granular cell tumor with inhibin and calcium.
So Santosh, Nita, can I ask you a question? Is juvenile granulosa more difficult to diagnose, and can it be confused with dysgerminoma, considering she's a young lady? So we'll keep the possibility of juvenile.
On a final histopathology, dysgerminoma and granulosa or a juvenile granulosa don't. So the problem comes with the juvenile granulosa versus an adult granulosa.
Yeah.
Okay.
So they have similar features, or if you don't have adequate material or limited material, you may confuse. But I don't think dysgerminoma per se, the cell morphology is completely different. Germ cell tumors have prominent nucleoli, more cytoplasm, whereas the granulosa are mostly ovoid to spindle tumors. So there is not. So if it's a frozen section, all I can still say keep the sections are not good, stained well or something. But final histopathology, dysgerminoma and granulosa generally would not be a differential generally.
The pregnancy can hamper typical histopathological feature of the granular cell tumor, sir. Pregnancy, can it hamper the?
No, I don't think so. We don't see too many pregnant female with granular cell tumor at all, to be very frank. But I don't think this tumor pregnancy can alter this morphology.
So, what is the role of the fertility sparing surgery for this patient, and what will be happen, and what would be their final treatment? It is already the metastatic granular cell tumor. The final histopathology report. Abraham sir or Amita ma'am, please.
I think I probably would not have done a cystectomy. I would have done removed the entire ovary. I would have done a omentectomy, and I would have any suspicious areas I would have biopsied. I would have checked. I mean, I don't know whether any imaging was done to check for lymph nodes and things, but generally granular cell tumors, we don't do lymph nodes unless they are enlarged. But there is fertility sparing. We can leave the uterus and the other ovary if they are normal.
So what panels of ISC markers should be advised to differentiate between granular cell tumor and dysgerminoma? What are the other panels? What we have done, all these are okay, sir? Abraham sir, please.
Yes, whatever IHCs.
No, I think Dr. Santosh should answer it.
Yes, the panel of IHCs would be inhibin calcium, which you have done, and a CKIT and a SAL4. SAL4 is a pan germ cell tumor marker. So now we have SAL4 with us, although again it has fraught with some but generally SAL4 wouldn't come in a sex cord stromal tumor. So basic panel of a SAL4 calcium inhibin and an OCT4 or something can clearly easily distinguish this.
So what is the final message for this? The final message for these patients, and she will go for the laparotomy followed by removal of the other ovary and omentum, and then adjuvant chemotherapy. So what will be the adjuvant chemotherapy for these patients in granular cell tumor? Dr. Joya, please.
So for this granulosa cell, if there are juvenile granulosa cell tumor, so this patient was, I think, sorry, I missed out on the age of the patient. So if she is a juvenile granulosa cell tumor, then we would use a BEP regimen, whereas for a patient with a adult granulosa, or somebody who is beyond the age of 40, we can use paclitaxel and carboplatin. Yes.
So these patients, Farhana?
Yes, madam.
Yes. This patient, she was diagnosed at her 20 weeks of pregnancy.
Yes.
Yes. and she delivered at her 37 weeks finally. Yeah.
Yes.
Yeah. So how can we avoid this type of emergency surgery in these cases? If a patient diagnosis at 20 weeks of or 25 weeks pregnancy with adnexal mass, and she was in follow-up and she has done emergency laparotomy, probably it may be with the torsion or any other things. For our audience, how can we avoid this type of emergency surgery?
No, so for this patient, if this is an operable mass, Dr. Amita can say, whether in second trimester you can, if surgery is feasible, whether one would want to go for a surgery first. But otherwise, if it is not, for a granulosa where paclitaxel is equally effective and, more easy to give, one could use neoadjuvant chemotherapy, although granulosa cell tumors are not very chemo-responsive. So whether surgery was feasible in second trimester, I think Dr. Amita can.
Is there any role of NSCT in granulosa cell tumor?
No.
Yeah.
Yeah, so I think if the question is how to avoid emergency laparotomy, I think the answer is if complex mass, fairly large size, like more than 8 to 10 centimeter, it's best to do an elective surgery in second trimester beyond like 18 to 20 weeks, rather going for an emergency surgery. And we can carefully monitor, but this mass, I'm sure on sonography would have shown solid areas, so definitely surgery was required. And if it was diagnosed at 20 weeks, I think surgery was done at 26 weeks.
Hello.
Someone has asked, Emily Nazrin, probably she's from Pakistan, is chemotherapy safe in pregnancy? It's already, it is.
Yeah, we've just discussed on that point.
Yeah.
Yes, so beyond second trimester, so there are some drugs, of course, which we never used in pregnancy, like, methotrexate. But for most of the drugs with which we can use in pregnancy, paclitaxel, carboplatin can be used in pregnancy. And BEP, of course, has been used in pregnancy, although, as I said, that, with cisplatinum, it is a bit of a challenge and of using during pregnancy.
So we can shift our third case. Farhana, please. Third case.
Our third case is Mrs. Y, age 35 years, para 3-1, diagnosed as a case of ovarian tumor at her 11th weeks of pregnancy. Her pregnancy was continued with that ovarian tumor by ultrasonography report. And she underwent laparotomy followed by excision of ovarian tumor, that is 15 into 12 centimeter, and lower segment cesarean section at her 35 weeks of pregnancy. Histopathology report of resected ovarian mass showed papillary mucinous adenocarcinoma high-grade. And after that, she was referred to NICRH. Here we did some diagnostic workup like CT scan of full abdomen, endoscopy, colonoscopy. We advised for slide review, immunohistochemistry report, and tumor markers. And patient was also advised for laparotomy followed by completion of surgery. Thanks to all for patience hearing.
There is the poll question is there. In 35 years lady, para 3, present with complex adnexal mass at 11 weeks of pregnancy, what should be done next? The poll question, please answer the poll question. When a 35 years lady, para 3, presented with complex adnexal mass at 11 weeks of pregnancy, what should be done the next? Please, the participant, please answer the poll questions. Tumor marker C125, CA, CA199, all the germ cell tumor marker, repeat ultrasonography of the lower abdomen after 1 month, LSCS at 34 weeks of pregnancy, and continue pregnancy till term. Nobody is answering. Okay, okay. Show the next poll question. Maybe please show the next poll question. If an adnexal mass is second question.
Madam, I can't show the full question. May Parnakalam, Madam, launch the full question.
Ovi, please. If an adnexal mass is suggestive of malignancy in first trimester of pregnancy in a multiparous lady, what should be done? Regular antenatal checkup with follow-up of adnexal mass by tumor marker and ultrasound, neoadjuvant chemotherapy and continuation of the pregnancy, laparotomy at second trimester, termination of the pregnancy, and evaluation of adnexal mass, followed by definitive surgery. I think it is already answered. So we are going for the chat box question. Farhana Kalam. Farhana?
Yes, madam.
Yes. Here her report is the mucinous cyst adenocarcinoma of the ovary, and whether the patient need confirmation the histopathology report, as because all we know there is 80% of the mucinous tumors are the metastatic. So should we go for in all mucinous carcinoma? Should we go for the metastatic warp or are there the primary source? Abraham sir or Amita ma'am, please.
No, I think the immunohistochemistry will give a clue whether it is CK7 usually for Mullerian origin, CK20 for GI, and of course there are many other IHC markers that might point. I think Santosh will be the best person to say which are the ones that point towards a GI tumor. But yes, if CA is high, then we have to look for a GI primary.
Yes, sir. So basically, if Paxate comes positive, it becomes a primary Mullerian mucinous.
Yeah.
Otherwise, in general, especially in cases of bilateral mucinous tumors, it's likely to be metastatic rather than primary. That's the other clue. And CK720, CDX2, that be to the other markers. But in some cases, even after a panel of markers, it would be advisable to do an upper and lower GSOP. So it's only confidently when Paxate comes positive that we are pretty sure that we are dealing with a primary mucinous.
My question to Amita ma'am,
Is
please.
that, sorry, Shahana, can I just ask Santosh,
Yes,
what is this papillary mucinous? Is there
Papillary is just a pattern, sir. It's the pattern of the tumor actually, but otherwise it's a mucinous tumor.
So
I think seromucinous now, WHO in the recent classification
Has removed, madam.
Yeah.
Seromucinous is out actually. So seromucinous are typically, they are now basically a Mullerian type of mucinous tumors which occur mostly in endometriotic patients. In 20-30% they are bilateral, and they have characteristic morphology with a lot of neutrophilic infiltrate, and they can have markers which are like for mucinous with serous markers and some squamoid areas. So generally they are associated with endometrium. That's the basic thing of seromucinous.
My question is, if you get this type of the patients, not in even in pregnancy or the without pregnancy, if we get the histopathology report mucinous cyst adenocarcinoma, in that cases, do you routinely go for the ISC? Abraham sir or Amita ma'am or Santosh sir, please.
Yes, we routinely do for mucinous tumors. We would do a panel of immunohistochemistry, which includes CK7, CK20, as Abraham sir had said, and Paxate and CDX2. But if you look at literature, mucinous tumors to identify primary versus secondary, there are certain clinical as well as IHC markers. So clinical would be bilaterality, younger age, a large unilateral large mass in the abdomen would be for a primary. If there is pseudomyxoma at presentation, generally it's a GI primary. So these are certain pointers which we use together to put in place to favor one over the other. But yeah, if Paxate comes positive and IHC, we would give a bottom line saying that this is an ovarian primary.
Yes, and Dr. Santosh, I just wanted to also ask, because many times these mucinous tumors, if they are not Paxate positive, they even mucinous of the ovary, can it be like CK20 positive, and that sometimes causes a confusion
Yes, yes.
whether
CK20 will be positive in many mucinous tumor, irrespective of GI or ovarian disease.
yeah, so that is why I
CK20
just wanted
doesn't
to,
differentiate a primary ovarian from a primary
yeah,
GI.
so that's
So
another
in
point that
primary ovary, generally CK7 is far more positive than CK20. So if CK20 is very much more than CK7, we again would favor a GI prime. So that's the thing. These are soft pointers. And one more thing, I don't want to complicate the matter, but in a mucinous ovarian tumor in a young patient, we would take multiple sections to rule out a background teratoma, because this might be mucinous adenocarcinoma arising in a teratoma. So that's something which we would always keep in mind.
But sometimes we have seen that even the GI workup in type of the big tumor, after GI workup, endoscopy, colonoscopy, everything normal, and there is no, even after that, we have found that the primary was the appendix. And how can you differentiate whether it is appendicular origin? What is the marker? And always
there is no IHC marker specific for appendix.
I think it's same like CK20.
Yeah, CK20, CDX2, SAT-B2 are the markers, but I think
same
clinically
markers, colonic
surgeons
markers
in a
are.
mucinous tumor would palpate would definitely check with the appendix intraoperatively. And earlier appendix used to be routinely removed. Now, if it looks okay, they are not. The appendectomy is not done.
Amita, would you, for mucinous tumors, would you remove the appendix or?
So we do actually many times, in final histopathology, we get the report primary, look for primary in appendix.
Yes.
So whenever we get, we remove appendix by and large.
I've also been, for mucinous tumors, I have been removing, but non-mucinous tumors.
Non-mucinous, definitely not if their appendix is normal, but mucinous we do remove.
But Amita madam, generally, if it is looking perfectly normal, these days it's not advocated.
Yeah, it is
routinely in every
not.
case.
It is not recommended. But many times, when the finals the report says kindly look for primary in appendix, then we are a little bit hesitant. And I mean, it's easy to remove appendix anyway in TROP, so it's not a big deal. So we, we remove. So.
But
The other question I want to ask you, Santosh, if you see borderline tumors, can you be sure that it's primary ovarian, or could metastatic
Madam,
tumors be
even
also
metastatic, like you said, appendix tumors can have present with borderline appearance of the ovary. So any mucinous tumor, irrespective of it being borderline or adenocarcinoma, GI definitely needs to be ruled out unless until, like I said, a Paxit is nicely positive in the mucinous stage.
But in advanced stage ovarian malignancy in mucinous, in that cases, after getting the patient, because I see the tumor mark panel was all in favor of the primary, and then the patient has undergone laparotomy, and during that time it was found that the appendix was the primary source. Appendix was involved.
Yeah. And many times actually appendicular primary lesion may not be very big. So it may be just at the tip something,
Yes, agreed.
hard nodule at the
appendix
tip.
tumors can be very small actually.
You have to very carefully look for appendicular, and it's best to remove appendix.
So we have a question in chat box that serous borderline has variant with papillary variant. Mucinous borderline has 2 types. Zero, which is already the Santosh sir, please. There is a question for you.
Sorry, I didn't get the question.
The chat box, there is a, you can just see the chat box.
Serous borderline has variant with papillary variant. Mucinous borderline has 2 terms. GI variant and seromucinous variant. A little complicated question. So serous borderline papillary. Let's forget the term papillary for a minute. I think papillary is just a pattern when we use it. So serous tumors can be serous borderline tumors, serous adenocarcinomas, and serous borderline can go on to develop low-grade serous carcinoma. So that's the serous pathway. Mucinous tumors can be borderline or mucinous adenocarcinomas, and even if they are borderline or they are adenocarcinomas, and if Paxit is negative, a mix of second 720 has to be done to look for a primary in the GI tract. So I hope I'm clear, because the question is not very clear to me.
Yeah, I think GI, I think it's gastric and endocervical type. Is that the
Yes,
question?
yes. So that's what we called mucinous or seromucins.
No, and
I
also
agree, Arpita, that appendix, I mean, current guidelines do not recommend to remove normal appendix always. So I agree with you.
So can we go for the fourth case? Farhana, please show the Dr. Sabrina's. Farhana, please.
Madam, here is a
she would
question.
also need,
Yeah.
sorry. She would also need adjuvant chemotherapy that I would mention that because she has a high grade tumor, even though she is an, I don't know the final stage. So if she's a high grade mucinous carcinoma, she would need adjuvant chemotherapy is all that I would want to say. With paclitaxel and carboplatin both.
Madam, can I ask a question? This is also from the chat box. Shushmita Sarkar asked to us.
Yeah.
That is, this pregnancy is continued with that ovarian tumor. Does she need any chemotherapy, and how could you understand without surgery that this is a mucinous variety? In that case, what chemotherapy should we choose here? Amita ma'am, please.
I see.
Are you trying to say during pregnancy chemotherapy without surgery?
And yes, madam, in this case, that is continued from 11 weeks up to 35 weeks
No,
without no
so
chemotherapy.
yeah, I mean, if anything, see, second trimester, we could have done surgery. If there was increase in the size, it grew up to what, 15 centimeter. Instead, I mean, we could have done surgery during second trimester sometime like
No,
20,
madam,
beyond
here we
20 weeks.
continue the pregnancy up to 35 weeks with
35
that
weeks.
ovarian tumor.
Right. So that's what I'm saying. Instead of continuing till then, if there was any doubt, we could have done surgery, just doing a biopsy in a adnexal mass which is well confined to give chemotherapy is not correct. That would have not been correct to do biopsy from the masses that to give chemotherapy. So if any intervention during surgery, during pregnancy, it should have been surgery early. We could have done surgery after second trimester. And based on the final report, in fact, if it was a stage 1A mucinous tumor, we wouldn't have given chemotherapy during pregnancy. We would have continued pregnancy and observed her. So Jaya, do you agree with me?
Yes, completely, because there, I think that is a dictum not only during pregnancy, but even otherwise, that if we have even if we have a large ovarian mass which is confined to the ovary and there is no disease outside the ovary, we will not biopsy the ovary and we will wait for a surgical resection and the final histopathology. Because just based on ovarian mass and tumor markers, we will never give chemotherapy. So that is there, and therefore definitely not puncture. And puncture in the mucinous is like a tragic because that would completely spill over. So I think surgery during second trimester, and then based on the histopathology, we couldn't decide. And especially if it is a low grade mucinous 1A, we would just observe this patient. Yeah.
I think, yes, the message should go out that surgery is the safest intervention.
Yeah,
during pregnancy.
absolutely. Yeah. I agree. And second trimester,
Yes.
after 22 weeks, it's quite safe to do surgery. I mean, she was lucky that you could continue with large mass and pregnancy till 37 weeks. But otherwise, we could have done surgery in the second trimester.
Okay, there is some question from Dr. Rohini. Probably the Shantosh Menon sir, he's already answered. There is a question from Dr. Jannatul Firdaus that can you please share your experience about the treatment plan and outcome of endometrioid variety? Abraham sir or Amita ma'am, please. Treatment plan and outcome of endometrioid variety.
Right, so same principles apply. I mean, you would have to do surgery and then followed by chemotherapy as early as possible. I mean, if it's, you would like to, finish chemotherapy at least 3 to 4 weeks before anticipated delivery. So, I mean, these are the principles. So, endometrioid, you would give carboplatin and Taxol in the second trimester, no problem.
Yes, I agree with Dr. Abraham that paclitaxel and carboplatin is very safe. I mean, some of the safest drugs during pregnancy. So if it is a high grade malignancy and you do surgery at 24 weeks, then, post that 3 weeks, we could give them 1 or 2 cycles. And another important thing, that whenever we are giving chemotherapy, we do get in touch with the obstetrician, and we do at least an obstetric scan each time before we give chemotherapy, so that, we are not taken by surprise, and we don't know that there is no oligohydramnios or any other fetal distress, which might lead to, delivery within 2 weeks. So I think doing because it's a 3 weekly cycle, doing a scan and talking to the obstetrician before each cycle helps, so that we can plan, as said, that stopping chemotherapy 3 to 4 weeks prior to the expected date of delivery.
Okay, we have two more cases. Farhana, please share the Dr. Sabrina's case. Farhana, yeah. Sabrina, please. Slideshow, please go. Yeah.
Assalamu alaikum, madam.
Yes.
So, welcome you all. Mrs. X, she is 21 years, primary, and attended outpatient department of a missionary hospital, Brahmanbaria, on 23rd July 2021 with 38 weeks of pregnancy and ultrasonogram diagnosis of pelvic mass. This mass was diagnosed during her 20 weeks of pregnancy. It was 18 to 5 centimeter, and she was continued with this mass till 38 weeks. And with these complaints, she underwent LUCS and left-sided salpingo-oophorectomy on 24th July.
Be next.
So this question has already been answered, that how this lady could be evaluated before surgery. So we all know that she should be evaluated with some tumor markers, and most important investigation is MRI abdomen. So my next question is to Professor Amita ma'am. If frozen section facility was available and it revealed malignancy, then what would be the ideal surgery? To do unilateral salpingo-oophorectomy and staging laparotomy during LUCS, or it should be done a two-step procedure, that LUCS early and then next staging laparotomy? What would be the best?
So it would depend upon the frozen section report. What was frozen section? Was it a germ cell tumor or a epithelial tumor? But ideal would be to complete, if the infrastructure is optimum, to complete surgical staging in the same sitting. And if patient is stable, if you are doing an elective procedure, we would complete the surgical staging in the same sitting. Of course, surgical staging does not always mean hysterectomy and bilateral salpingo-oophorectomy. If fertility preservation is required, based on the frozen section report, we could have done conservative surgery with surgical staging, in the sense of mentectomy and assessment of other disease sites.
So, madam, where facility is not available, two-step procedure is also considered.
Yes, I mean, two-step, but adnexal mass you will remove. I mean, not that you just deliver the baby and leave the mass. That you will not do, even if frozen section is not available. You will remove the mass and do cesarean section and wait for final histology.
Okay, madam, thank you. So, she underwent LUCS and left salpingo-oophorectomy. Was performed, and it revealed there is borderline tumor, atypical proliferative borderline tumor of ovary. So my question is to Professor Santosh sir, what is the importance of micropapillary pattern in serous borderline tumor, and how it, what is the possibility of its converting to malignancy?
No, there is here first histopathology report. It was serous borderline tumor macropapillary type. The second person, the review slide shows papillary serous tumor. This is more or less the same atypical proliferative borderline tumor of the ovary. So next, Farhana, next, yeah.
So with this scenario, she was referred to NICRH. So how this lady will be managed next? As she has borderline tumor and she has undergone unilateral salpingo-oophorectomy, whether follow-up is enough for this lady, or staging laparotomy is a mandatory?
Abraham sir.
I mean, if she's young and still wants to have children, I
18
would
years.
be conservative. I would
Eight-
wait. I wouldn't be in a tearing hurry to go and do any staging at this for borderline.
Okay, and if she doesn't want any further pregnancy, then staging laparotomy should be done.
I mean, yeah, if I'm assuming that the imaging and all has been done, and if there's, I'm absolutely no worry about disease, then I would wait. But otherwise, there's no, at a convenient time, we would complete the staging or complete the surgery.
But
Okay,
I have a question to Santosh sir. It has the micropapillary, serous borderline micropapillary. As we know that borderline tumor, it has the chance of invasive is 8%, and if it is micropapillary, it is around 27%. So what will be the next treatment plan? Santosh sir, please.
Sorry,
Yes.
Dr. Shana, I don't rate the patients. But yeah,
Yeah.
micropapillary, the main important thing about borderline tumors is we extensively do look for micropapillary pattern,
Yes,
because
sir.
those are associated with invasive implants in the peritoneum and omentum. And once you see those micropapillary pattern, we extensively also sample omentum and the peritoneal biopsies which are submitted, so as not to miss this invasive implants. So that's the connotation of seeing a micropapillary pattern in a borderline serous tumor. And in a report, we do mention the percentage of micropapillary pattern. Because generally, if there is extensive micropapillary pattern, the chances again of having invasive implants in the peritoneum and omentum are very high.
I mean, Dr. Shahana, I suppose the invasive implants were ruled out at surgery, right?
No, sir. Just this patient, she was diagnosed at her 26 weeks of pregnancy, adnexal mass, and the pregnancy was continued up to her 37 weeks. And 37 weeks pregnancy, LSCS with excision of the adnexal mass was done, and it was done around 8 months back. And after 8 months, today she's attended in our hospital with she was attended in the oncologist, the clinical oncologist, and she was advised the review of the slides. And that time the first report was at the local hospital, and second report, the review report, was that it is the another hospital, and the report was like this. Then the patient was referred to in our hospital. So our there is the micropapillary type. This is only written in the histopathology report. So what should be done for this patient? As all we know, the micropapillary type, there is the chance of invasiveness is more. In that case,
Dr. Shana, we don't report borderline tumor micropapillary type as our final diagnosis. We would say that the tumor has 10% micropapillary pattern or 20%.
Yeah.
So with increasing micropapillary pattern, the chances of having invasive implants are increased. That's the main thing. So an extensively micropapillary tumor, which is completely micropapillary, would be almost be like a low-grade serous carcinoma. So the American people actually label micropapillary type completely of tumor which is micropapillary type as a low-grade serous carcinoma.
Okay, sir. So our last question has already been answered, that as her histopathology shows micropapillation, what if it is a extensive micropapillation, then adjuvant chemotherapy would be needed or not?
No. So I think it is clear that if we have borderline tumors, even if it is a stage 3 borderline tumors, they do not need adjuvant chemotherapy. It is observation. But whenever we have implants into the omentum, we need to see whether these implants are invasive or whether these are non-invasive. So if we have invasive implants in omentum, then that becomes like a invasive carcinoma, in which case she needs adjuvant chemo. But if it non-invasive implant, and it is especially if it is a tumor confined borderline tumor, then they do not need adjuvant chemotherapy. And micropapillary, will have an increased, as Dr. Santosh mentioned, risk of invasive implant, but that is why they sample extensively. But if there are no invasive implants and it is a borderline tumor, then just because it has micropapillary pattern, that is not an indication for giving adjuvant chemotherapy. So no adjuvant chemotherapy is the bottom line for her. For that, if she has, I assume that she's had a CT scan, and if she's not had a staging laparotomy with such extensive, so we would need to know the omentum I mean, I don't know, Dr. Amita can tell me that.
No, she has come just today in our hospital. We advised her the CT scan and the other tumor marker, everything. But
Yeah. So
will
what
we go for the comprehensive staging leopard fertility sparing surgery? Do a staging laparotomy? Amita ma'am?
Yes, I mean, see, I think we need to, as Dr. Santosh mentioned about the quantification of micropapillary, just, occasional micropapillary versus extensive. And if she's keen, I think she's primary gravida young lady. After counseling the patient, fertility sparing surgery is can be recommended to her. So if she wants further fertility, we can do conservative surgery.
Yes, she's 18 years and the 8 months is baby. There is one question from Mo Roy.
And I just want to make a comment here, although we generally ask for CT scan, but my personal experience is in such cases because the commonest site apart from momentum is other adnexa. So maybe a good idea to do MRI of pelvis to carefully look at the other ovary, because intra many times you may just find some cyst and not very sure what to do. So if you have a MRI preoperatively, that I find quite useful. So of course, generally we do CT scan, but in this kind of situation where other adnexa preservation is a concern, then I think my personal choice would be a MRI.
Santosh sir, there is a Dr. Orpita. He mentioned we can, we can know the implants by doing the comprehensive staging, and can the board take my question on mucinous borderline with microinvasion? I don't know what she want to mention. This is the last question in the set box. If a young nulliparous patient has undergone laparoscopic cystectomy, if the histopathology is borderline mucinous with macroinvasion, would you advise unilateral sulfing oophorectomy with infracolic comentectomy and unilateral sulfing oophorectomy with infracolic comentectomy, ICU with retroperitoneal lymph node dissection? What is your opinion? Abraham sir or Amita ma'am, please.
I wouldn't do lymph node dissection for mucinous.
Yeah, so I agree with Dr. Abraham, unless nodes are enlarged or suspicious in a mucinous tumor or even, serous borderline, we do not routinely do lymphadenectomy or PLNT.
Okay. We have another interesting case, and it is from the Sir Solimullah Medical College and Mitford.
But just one point, if nodes are enlarged or suspicious, so we will address them, remove them.
Yes, ma'am. Thank you. Yes. Thank you. We have the last case, sir. Please, everybody has requested to wait. It is an interesting case, and it is from Sir Solimullah Medical College and Mitford Hospital. She is Dr. Mahmouda. I request Dr. Mahmouda to present your case. Mahmouda, please. Dr. Mahmouda.
Yes, ma'am. Can you hear me?
Yes, please share your screen.
Yeah. Thank you, Shana madam, for giving me the opportunity to present my case here. So on behalf of Department of Obstetrics and Gynecology from Mitford Hospital, I'm presenting our case. Mrs. X, a 21 years Nalipara lady, attended a local clinic on 5th January 2022 with 25 weeks, 6 days, single alive pregnancy with each presentation and 11.2 into 8.2 centimeter ovarian cyst. She was referred to an obstetrician, and there further evaluation was done. All investigations there were found normal except TSH and FT4. TSH was found 120 and FT4 0.28 on 5th of February 2022. Then thyroxine was added, which was gradually increased up to 150 microgram. And And the patient was then followed up at 28 weeks, 30 weeks, and 32 weeks with the transabdominal ultrasound, but the size of the ovarian tumor was increasing rapidly. And it reached from 11 centimeter up to 44 in 40 centimeter. But there was no comment regarding the origin of the tumor and whether it was unilateral or bilateral. With this, the patient was referred to our hospital for further management on 25th of February 2022. We evaluated the patient. Her TD is on 14th of April 2022. She took letrozole 2.5 milligram, but she cannot mention whether she took it 1 or 2 cycles. Her other history was nothing contributory. General examination was normal. Per abdominal examination, we can see that hugely distended abdomen is a uterus, and the cyst was actually just in the upper abdomen. This is the abdominal ultrasound report, which showed hugely enlarged bilateral multiloculated cyst. Her TSH report, it was on 120 on the 5th of February. And with discussion with endocrinologist, we continued the thyroxine 150 microgram. And on 5th March, we found her TSH more than 100. And 54, it was actually in better position. In 8 on 5th of February, and 1.2, it was on 5th of March, just after 1 month. Her serum potassium level was slightly reduced, 3.32. But all the other electrolytes were normal. We did the tumor markers, but all the reports were near normal except alpha fetoprotein, that was 177. Here's the MRI report, and we can see that bilateral ovarian cyst here. Here is the transverse section, ovarian cyst, and this is the fetus. It is presentation still now. This is the MRI report. So you can see that bilateral, they reported as it is 34 weeks of single alive fetus with bilateral large multiloculated adnexal cystic lesion, possibly thecal uterus cyst, and maybe ovarian hyperstimulation syndrome. We did the transabdominal ultrasound with color Doppler report, and here it showed resistance index 0.48. The transabdominal ultrasound showed no papillary projection, no solid component, and no irregularity. Site of the origin was not identified, could not be identified, and they reported as borderline ovarian tumor. So we diagnosed it as a case of PRIME, 35 weeks, 3 days, single live pregnancy with breech presentation with bilateral multiloculated large complex ovarian cyst with hypothyroidism. So now the case is open for discussion in this multidisciplinary tumor board. Shahana madam.
The floor is open. Abraham sir, Ovita ma'am, please. Abraham sir.
Yeah, I think this ovarian hyperstimulation syndrome is to be considered. Very high levels of TSH could have an effect on that.
Yeah,
So
I
at the
agree.
time
That's my, sorry, go ahead.
Sorry, go ahead, Amit.
No, you please continue.
I mean, the other tumor markers were normal, right? So I think this is more of a benign condition. You wouldn't, decompressing the ovary sometimes may help. If at the time of delivery, we could probably address that.
It is only 32 weeks pregnancy, sir. It is 31 or
35.
Now maybe 35 weeks, 5 days today.
Yeah. And her TSH is still 100, yeah?
More than 100, yes, madam.
Yeah. Hugely distended abdomen. And what will we do with these patients, or what will be her mode of delivery?
No, I think we'll have to control the, we'll have to adjust the dose of, thyroxine.
Yes, it is gradually, the dose is gradually the increasing, sir.
We
if
consulted
you
with
can,
endocrinologist.
Yeah.
I mean, see these sort of cysts need not be surgically removed. I mean, if it's causing a lot of discomfort, they can be decompressed, and she can deliver vaginally.
Sir, patient is
go ahead.
primary. Sir, patient is primary and still the baby is in breech position, sir, breech presentation.
Obstetric indication, that's different. Obstetric indication for cesarean section to cesarean section. At the time of cesarean section, we can decompress the ovarian cysts.
So
I wouldn't remove the ovaries.
sir, patient has respiratory distress, probably she can't move, and can they go for the decompression of the cyst?
Yes.
Yeah.
We can even, I mean, this is, I mean, ruling, there are no solid areas. This is likely to be because of the hypothyroidism, it's most probably due to that. So we can decompress it with under ultrasound guidance. Amita, I would like to hear what
Yeah, I agree. And have you done her CEA levels?
No, madam, no.
I mean, the only other differential would be mucinous tumor. Although in the given clinical context, it's more in favor of hyperstimulation kind of picture what Dr. Abraham just mentioned, and I think that would be the appropriate treatment. But we should just do a CEA level.
Sure.
Yeah. They are advised for CA level. Probably they missed that. At the same type of case, the 6 months back, they had facing the same type of case, but that was an early weeks of pregnancy, around 12 weeks of pregnancy. That time her TSS was also in 120, and the patient she was treated with that levothyroxine, and it is probably the patient received 4 tabs per day, and ultimately the tumor size was reducing at the end of the time of the delivery. The size of the ovary was normal. I think it will be the same. Yes, that is the end, and I think this is the end of the session, and we are very much happy, and we are very much lucky today that we have the 4 renowned persons with us today. Now I request our scientific secretary, Dr. F.M. Kamaluddin Bhai, to conclude the session.
Shahana, can I have a question, please?
Yes, Appa. Yes, please.
Assalamu alaikum. Thank you, Shahana, for inviting us and give us the opportunity to present the case in such a multidisciplinary tumor board with some international experts are there. We are very lucky to have those experts in our discussion, no doubt. So one of my questions to our multidisciplinary tumor board, so your opinion is if we go for elective cesarean section, because in our primary patient, we actually, for better fetal or neonatal outcome, we offer after 38 weeks completion, elective cesarean section usually done for breech presentation and primary gravida. So at the time of cesarean section, if we go for decompression of the cyst and we found that incidentally there is mucinous material coming from the cyst, what would be our next workup in that case?
At first, you will have to go for the CA level before that.
CA.
Yeah. We are advised. Amita ma'am or Abraham sir, please.
I mean, if you ideally, then if it looks like mucinous tumor, frozen section facility should be there. And if it's bilateral mucinous, what we discussed before, again GI workup and all that. But in this patient, it looks more in favor of hyperstimulation than mucinous tumor. But if her CEA levels are very high, then we have to, consider that possibility, and she may require GI workup, GI evaluation.
Okay, ma'am. Thank you.
Would you like to any more question ask? Please. Do you like to ask any more question?
So if CA level is will be found sufficiently raised, what will be our next workup? Should we go for endoscopy or colonoscopy in this pregnancy, advanced pregnancy?
That's a good question. If your GI endoscopists are comfortable doing, yes, we should do a GI workup. Otherwise, at least stool for occult blood and maybe MR can tell us about many times on MR, we can see a lesion in the colon, if anything, in the bowel.
So before colonoscopy, we may go for the occult blood test. If occult blood test is positive, then we can think of that.
Yeah,
Okay.
and MRI also can be useful.
MRI already, MRI, non-contrast MRI done. Yeah.
Non-contrast.
Dr. Jappa, do you like to ask any more question?
Okay, if I get opportunity to present the case in your next Sunday, so I will be happy to have the CA report with us.
Okay, thank you, Appa. Thank you very much. I think we are now at the end of the session. Yeah, and I am very much grateful to all the faculties. Now I request Dr. F.M. Kamaluddin Bhai, our scientific secretary, to conclude the session.
One question, Dr. Shahana.
Yeah.
Should we decompress the tumor before cesarean section?
If the patient complains, they have already, it is already answered. If the patients they complain,
No, patient has no complaint yet.
No,
Patient has no complaint.
Yeah. Kamal Bhai, Mehdi.
Yes. So thank you very much for the wonderful program. I think what I overheard, I will rather say, because I was not taking active part, that every case that was brought was head scratching, and even our expert were, I mean, they were thinking twice to give an opinion because these were so interesting, because in oncology, there is no 2x2 issue. But I'm so grateful that Amita, Dr. Abraham, and Jaya and Santosh all gave their valuable time. And I'm sure it was quite encouraging and enjoyable, enlightening, because these are not a common thing we discuss, but this is an everyday problem gynecological colleagues face. So this is an area which was not covered earlier, and I'm happy that this was brought up. And Oncology Club will continue this type of endeavor in future, and this will be only possible if you people provide us support by joining the program, because we are confident that our friends from overseas, they will be continuing their support like earlier, and we will be enjoying their support. So they will support us, and we will continue these things provided there is a demand, and you can prove your demand by joining the program and putting the number of participation more than 100 like today. Thanks to all, and thanks to Shahana and Farhana Kalam and Dr. from Salimullah. Sorry, I cannot remember the name. And the presentation was really, really wonderful. I'm amazed with all the presentation and the discussion. What I learned is really interesting. Thank you very much.
Thank you. All right. Thank you very much. Good night, sir. Thank you, sir.
Thank you, Dr. Shana, Dr. Kamal, Dr. Abraham, and Jaya. Bye. Good night.
Good night.